So first of all, thank you guys. I hope you guys are still energetic enough for 2 more hours. It was just a change in the program. So here are my disclosures. So we're going to start out with a first case. Our first case is a patient with multiple myeloma. So here's the case: 72-year-old who had donated a kidney and subsequently developed biclonal IgG kappa gammopathy. That was first diagnosed in 2005, had been monitored. At that time, she had a bone marrow biopsy, showed 9% bone marrow plasmacytosis, small M protein, and had been monitored. Anybody wants to make any comments? Is this appropriate at this time? The myeloma docs, both of you are sitting next to each other. Is this appropriate to monitor someone like this who's donated a kidney, or should we have treated her right away 9 years ago?
No. So far, so good.
So far, so good? Okay. All right. So October 24, because her renal function deteriorated just a little bit, you can imagine after a kidney transplant, a creatinine normally runs at around 1.2. It was about 1.5. And so she got blood testing. We showed free kappa of 1,119, which had increased from December 23. Free lambda was about 16 with a markedly abnormal kappa lambda ratio of 67. Creatinine somewhere between 1.37 and 1.5. And albumin was 3.8. Immunoglobulins, IgG was 1,500, IgA was 58, and IgM was 172. Should we do anything else, or what should we be doing at this point?
Yep.
Dr. Gertz is, he's looking. I mean, he's looking at you guys and saying, "What are these young kids doing?"
24-hour urine protein excretion is, how much of that is albumin, and how much of that is light chain. So, you still need additional information. You cannot make a decision.
Yeah, I think my recollection of, let me see if we have that.
October of 2024, is she now 87 or is she 72 now?
She's 72 now. She's 72 now. She had probably 100 milligrams per deciliter of free kappa in her urine.
We were in consensus that in addition to what Maury suggested, we would also like some imaging and bone marrow.
Was there a serum erythropoietin level checked at the time as well when the hemoglobin was dropping? The patient has 1 kidney.
I believe it was, and I think it was normal. And I may be making it up.
Sounds like it.
Why didn't you tell us what the M protein is now? You said small M protein there. Is it that it's still insignificant in October 24?
I believe it was probably about 0.8.
Okay.
In the hemoglobin, it may be that the anemia will be explained by significant marroplasmacytosis that will obviate the discussion of the creatinine and the urinary protein. 9.7 is not normal, even with that creatinine, and that would fit with a 40% or 50% plasmacytosis, and then nobody's going to be questioning what to do.
So what's next?
All right, can we get the slides back? So the obligatory bone marrow biopsy was done, and bone marrow plasmacytosis is 8 to 12%. Negative fish panel for myeloma, and normal cellular marrow otherwise.
What's the imaging?
PET is negative.
And is it that the... What's up, Maury?
He's looking at the free kappa, I'm sure.
No, I'm looking at the total urinary protein.
Yes, okay.
Critically important.
Yeah.
Yes.
This patient is not filtering light chains through glomerulus.
Yeah.
So what do you think she's doing?
When in doubt, don't. That's the moral. Bring her back, I don't care if it's in a month. Because I don't know what the creatinine of 137, is that 137? Next repeats 127, next 1.7. But that is a very low amount of urinary protein. And it's important to look at that very high light, that you also look at what's going through the kidney if what you're thinking about is treating to prevent calcipropathy. This is not a very high risk.
So are you suggesting a kidney biopsy?
I am not. No one in my place will do a kidney biopsy. Someone who has 150 milligrams of protein in urine and a 70-year-old with a creatinine of 1.7. They'll say, I'll see you in a month.
So a month later, she's about the same.
Sorry?
A month later, she's about the same.
Oh, then I refer her to his body.
Yeah, who would continue
Okay,
to...
so sad. You've seen her memorial, and creatinine is about the same, and it was actually also monitored a little bit of time before the bone marrow, so we didn't really just go straight to the bone marrow. And the PET scan is negative. So there are a couple of questions. Do you think that it's possible that the patient's bone marrow biopsy is a sampling error, and that maybe we should go to a different site and repeat the bone marrow? Would that be something you guys would consider? Or would you do an MRI, or would you do something else?
No, I don't think so. I think the PET scan is negative in this patient, and even with this elevated light chain and abnormal ratio, the fact is you still don't have an end organ damage. So I would follow this patient very closely, probably doing monthly labs and seeing the patient every quarter, and just looking for the sign. I would like to find better explanation for that hemoglobin of 9.7. Is that a one-time value? Does it go up or down? With one kidney, you can have some degree of anemia of CKD as well. So,
So as the alcohol is being served, I think Michael has a question about this case.
No. I have a.
I'm not
You
sure.
finish yours, and I have my own.
Oh, okay, good. So
thing I'm trusting is that 150.
So another question, Maury, maybe I could start with you since these guys are busy with the alcohol. What do you think about doing a kidney biopsy in a patient with one kidney? Is that an absolute contraindication, or?
I'm not doing a kidney biopsy in someone whose creatinine is 1.37 and has proteinuria of under 200 milligrams. That is just not an indication. It's monitoring the hemoglobin, monitoring the creatinine, and the question about a repeat bone marrow, you monitor, hemoglobin drifts down, comes back 8.5 in 4 months. I might repeat the bone marrow at that time, but right now, I'm quite happy to monitor closely. Look, if this patient is treated, they're going to be seen weekly. So I'm not going to treat them, and I'll see them monthly.
Can I ask a
How
question?
can there be 857 milligrams of a liter of light chain is only 150 milligrams? So
That-
we pee a couple liters a day.
That happens because in some patients, those light chains are not circulating as monomers. And so they're not making it through the glomerular basement membrane in through the tubules. And it's important. It's one of the smoldering myeloma.
But they're in the urine, it says.
No, just 150.
I hate to say this, we don't do any light chains in the urine because it's not a validated test. We never measure it. You ever measure it?
No, I've never measured it.
So we don't even know what that means because I don't know what the validation is.
Seems a bit
Can I
mathematically
ask
strange.
a question?
I hear you.
So
That'd be 8 grams.
the hemoglobin of 9.7 cannot be explained by the number of plasma cells in the bone marrow.
No.
to be
So
valid.
perhaps you could get your answer by looking at perhaps cytogenetics, NGS, see if there's an alternative explanation for the hemoglobin. Perhaps that could pivot the discussion a little bit.
And I don't think that we did an extended NGS. I think it was in myeloma fish panel. So I don't recall that was done, but that's a good point.
Very bold, very bold.
Oh boy.
Oops,
I can't read.
sorry.
But just tell us what it is.
Oops. Oh, there it is. Oh, actually, okay. So what I did not tell you is that the patient also has hypertension that she claims is white coat syndrome. Um, and it was important for nephrology because the patient has one kidney. They wanted to kind of get an understanding of what was going on with her because her creatinine never really has gone back to her baseline over the period of time that she was monitored. But Maury was up to something because this is what they said. They said they thought it was physiologic trafficking of SS filter kappa light chain versus early mild, what did they say, versus early mild non-crystalline light chain proximal glomerulopathy. But in the end, they said that they favored hypertensive disease and that the free light chains that they saw were trafficking. So what does that mean? Is that what you were describing?
I just didn't think it was related. And of course, the patient, no matter what we do, is still at risk continuously for the rest of her life, but not now.
All right, patient is being monitored. Any additional comments?
I don't, are you attributing the anemia from the creatinine?
Maybe some degree of renal insufficiency.
What was the,
I can't remember the exact number, but it wasn't terribly low.
Blood pressure isn't that well controlled.
So control the blood pressure, monitor her.
BMI 38.6. Not the only problem then.
Yeah,
Any additional comments?
I'm with Dr. Teferi. I mean, does the anemia remain stable over time without any considerable changes and never explained?
You know, it's kind of wax and wane. So one of the things that I will take from this is that potentially we could still send the bone marrow, at least for NGS testing, and see if they see any, kind of do a full panel NGS and see if they see anything else. You could still do that. Yes.
I'm
sir.
assuming we evaluated for other causes of anemia, iron deficiency, B12, and all those other
Yes.
things.
The obligatory iron deficiency has been done 3 or 4 times. And the thyroid function test has been done 7 times, maybe.
You have to think about anemia of chronic inflammation along with CKD with that, obesity as well. So, sounds like metabolic syndrome here.
You think we should give her a GLP-1 inhibitor? All right, so Jen, you're on the and anybody can. So this is a 78-year-old who presented in February 23 with asymptomatic leukocytosis. White blood count was 44,000. Flow cytometry confirmed CLL, rise to 0 CLL with a 13Q and an IGVH unmutated status. So what do you make of those two things? I mean, 13Q is supposed to be a good thing, and now she has the IGVH. Are we supposed to just be happy that she has the 13Q and ignore the IGVH, or how would you approach this?
Yeah, generally the IGHV will trump the cytogenetics, so we would expect her to behave like somebody who has IGHV unmutated. All
right, so at this point, should we jump up and down because she has an IGVH unmutated status and immediately start FCR chemotherapy, or what should we be doing?
Yeah, actually, probably not, but we were just discussing, there's an early intervention SWOG study that's going on right now, but it's for high-risk CLL, and I think, based on the IPI, she would not be high-risk. But for now, we would want to just watch her.
Dr. Stone, you agree? I see
I'm
you.
not going to disagree with that. But how high risk do you have to be to go? So
You have to have-
unmutated status is not high enough?
No, by itself. So unmutated is going to give you a
We're
point.
talking about, just to explain, but
Yeah.
we're talking about,
So this is SWOG, I don't remember the number off the top of my head, 1902, I think, and it's venetoclax plus obinutuzumab, either given in an early or delayed in a randomized fashion for patients within 18 months of diagnosis. This is an intergroup study, so it's probably available somewhere around here.
these are for patients who wouldn't normally be treated
Correct.
by clinical criteria. We're worried about the biological.
Yep, and it is based on the CLL IPI score, and they have to be high or very high risk. I think with just IGHV unmutated, older, but no lymph nodes that you can feel, the beta 2 microglobulin, I assume, is actually probably like 2.76 rather than 27.6, so that'd probably end up being intermediate.
We'd watch the patient.
Watch this patient, yep.
So, does the beta 2 microglobulin come into play at all? I remember, Michael Keating at this very meeting said that beta 2 microglobulin is the mother of all tumor markers for prognosis in all hematologic malignancies. What
So
say
is it
you?
actually 27?
Yep.
Okay. I would guess it is probably 27 for some other reason, unless you see over a very short period of time that it's going to behave very aggressively. With a normal LDH, though, I would guess that this beta 2 microglobulin is elevated for some other reason. Not for CLL.
So from 23 to 24, about a year later, the white count is significantly higher. The patient is lethargic, fatigued, has progressive anemia. So the patient meets criteria for therapy. I don't have those numbers. And so the patient's initial therapy was obinutuzumab and venetoclax because of a desire for fixed duration therapy. But patient ends up in the ICU with his first dose of obinutuzumab. So that's abandoned, and the patient is then what should we be doing then?
So I guess, do you have NGS or anything else that would suggest a reason why they're behaving so aggressively?
By recollection of looking at the case, I don't think anything else came up on the NGS.
So I think if you're not going to give the obinutuzumab, you do have the option. You could just do venetoclax by itself. It's not going to be as effective, but could be considered, especially for a 78-year-old. Now I would also consider if she was really wanting to do a fixed duration regimen, I don't see a reason why necessarily she shouldn't. You could do acalabrutinib instead of the obinutuzumab.
So talking about the NGS, were you thinking more of like a P53 or some other bad mutation?
Yeah, I would be concerned that she actually has a P53 mutation, or I suppose it could be something else like Notch1, PTAPN11, something else that's going to be very high risk.
Okay. Now let's say a patient like this presented in 23 and you did NGS and there was nothing. Would you repeat the NGS at the time of progression, even though it's that quick, or would you say that's close enough, you shouldn't worry about it?
It depends. I think if the entire clinical course was pretty linear, it behaved aggressively the whole way until it required treatment, I wouldn't necessarily with such a short time interval. If it's something where everything was stable for a year and then all of a sudden became much more aggressive, I would repeat it at that point. And I also might consider, depending on the clinical scenario, I might consider also looking for Richter's transformation prior to starting too.
So would you do a scan, or would you?
I guess it depends on how fast these symptoms occurred. Is the LDH really high now, or is there anything else that would suggest that this has transformed? I would have a low threshold to do a scan, though.
All right. So based on your suggestion, acalabrutinib was initiated in May of 24. So fast forward, the patient is one of those that looks at the literature. So now the patient is calling as of January of 25 because they've heard of the amplified data. And so they're asking a question: should I not get venetoclax at this time and do time-limited therapy? But the patient has been on almost 6 months of acalabrutinib, which is not how the study was designed. So what say you, Jen?
I think if it was somebody who had been on acalabrutinib for 5 years, I would say no. If somebody who is so close to starting the acalabrutinib, I might consider if they really wanted this fixed duration. There also is a new study, the BRAVE trial, which is run by Genentech, which is taking people who have had at least 6 months of any covalent BTK inhibitor, adding venetoclax in just that manner, so a year, and then looking to see if they have MRD undetectable CR, in which case they could stop all therapy. Otherwise, they could just go back to their covalent BTK inhibitor if they want to. But I would consider a trial like that if that was an option.
Okay, so if you were to do venetoclax in a patient like this, when do you count the time of initiation of therapy? You count it from the day you started the venetoclax, or when?
Yeah, so I mean, in most of the studies, venetoclax is given for 12 months. And it's usually 3 months or 2 to 3 months of BTK inhibitor beforehand. So I would do 12 months of the combination. Or you could do 2 years, I guess, if you
I was
wanted
hoping
to.
you would stand
I
up.
hope you would do it in the context of a trial.
Let me just give the alternative hypothesis. If this patient had come to MD Anderson in April 2024, what was the white cell count? What was the white cell count in April 2020?
I believe it was, if I remember correctly, it was probably about somewhere between 80 and 100,000.
Yeah. So an infusion reaction is not a contraindication. You can give 50 milligrams of obinutuzumab with steroids, and you can reduce the counts very quickly. You can repeat another 50 milligrams on day 2, and then you give the 800, 900 day 3, and I bet you the white cell count will go from 100,000 to 5,000. The second thing is, at MD Anderson, this patient would start on the couplet for 2 years, and she will do very well on that. I worry about the beta-2 microglobulin. Now, the beta-2 microglobulin was very high. If the creatinine is normal, you have to find why it was so high. So I would have done a PET-CT, and I would certainly try to do a PET-CT at the second presentation. But today, this woman is here under your care. I would tell her, let's try back the obinutuzumab, 50 milligrams with steroids, day 1, day 2. You want to reduce the counts very quickly. If the counts are already down on the acalabrutinib, I would certainly add venetoclax and continue the 2 for at least 1.5 years to 2 years. But you want something that's potentially curative. She's 78, she could live to be 90, 95. You don't want to keep giving her one drug and the other. Give her something that is potentially curative in chronic lymphocytic leukemia.
Jen?
I mean, I guess I would start by just saying I was taking the case at the face value of after everything had been discontinued and starting again. If they had come to Ohio State initially, we probably would also have put them on a clinical trial. I mean, you know, the 3-year EFS with acalabrutinib plus venetoclax and Amplify was still almost 70%. I think that it would be reasonable to do the acalabrutinib plus venetoclax in the same way it was done in that randomized phase 3 trial.
So talking about gonadal fortitude on a patient who's ended up in the ICU, do we do as Dr. Cartwright just suggested and just make sure we hold our gonads up in our teeth?
So, I mean, I think Dr. Kantarjan is absolutely correct. Like, you probably could have reinitiated the obinutuzumab if you wanted to, as well if you gave the, if you had started the venetoclax then, gotten the white count down, you probably also would have had a pretty easy time reinitiating the obinutuzumab. I think that, you know, the complicating factor is the patient probably didn't want to restart the obinutuzumab, I would guess, like having ended up in the ICU. And I think there is an alternative you could do, but obinutuzumab you could certainly have tried again as well.
Remo?
So I don't do CLL directly, I used to. But I'm trying to understand something here. I mean, if you are from MD Anderson with Hagop, and you believe that you can cure this patient, I can appreciate that you would be aggressive. But if you are in most of your group, where you suggested that you can't really cure CLL, which I agree with, by the way, then what is the, I mean, she's doing fine. This is a 78-year-old lady, got her on acalabrutinib. What's the urgency? I mean, why don't you just let her be? and if she acts up, then you've got an arsenal of things you can use, pertortunib, whatever you want. So what is the rationale for trying to sneak in, especially when she told you, I can't tolerate this with a grade 3 infusion reaction? I'm trying to understand.
I mean, I think we're lucky that there is a lot of ways that you could approach this and still she would do very well. I mean, I agree. I don't think that you need the obinutuzumab. You could always consider, if she needs another line of therapy, doing something with obinutuzumab later. You could just give her, like you say, you could just give her acalabrutinib and move along. If she really wants to have a time-limited treatment, though, the frontline therapy is the best time to do that, because if you wait until the second line, you're probably not going to be able to give a time-limited and actually have a prolonged remission duration. So, doing something to be able to discontinue the acalabrutinib, I think, is reasonable as well.
Acalabrutinib is over $200,000 a year for an indefinite treatment, 10 years. That's $2.5 million. If you can give a finite therapy that's potentially curative that you finish in 2 years, that will be much better for the potential cure and the quality of life of the patients. And 78 is not old anymore. People are living till their 90s. So you cannot just say, oh, this one is 75, why worry about that? All of us are going to be 75 in 5 years. So let's try to give curative therapies for these patients.
All right, Ralph.
So I love this discussion because it's so practical for the clinical type of patient we see every day in practice. But I want to go back to what you just were discussing with regard to the white count. We ordinarily, if we're faced with someone who has 60, 80, 100,000 white cells, we're not giving them obinutuzumab at even 100 milligrams, to Dr. Kantarjian's point, on day one. And if it's per Murano or something, when it's relapsed disease and you're giving them rituximab, it's the same thing. We typically try to give them very small doses for a couple of days for that exact reason. And so I just wanted to ask you two to discuss this all over again in how you would approach a patient with a high white count, because that's not the way we would have managed it.
Jen, what would you do? Would you give 25 milligrams or 50 milligrams? Or
So, I think the definition of what's too high for obinutuzumab, I think, is a little relative. I would probably go ahead and give obinutuzumab first up to maybe 200 or so in CLL. And of course, other lymphomas are different. Sometimes we'll try giving a little bit of steroids beforehand if you're really concerned. I think, there was a couple of abstracts at ASH that were really interesting. In the CLL14 trial, the only tumor lysis syndrome that was seen was with obinutuzumab. And at ASH, they had a couple of abstracts from different groups looking at sequencing, like doing the obinutuzumab first or the venetoclax first. And actually, there was less tumor lysis if you gave the venetoclax first, which we don't do, but is interesting.
So we had many meetings in leukemia at MD Anderson because we had this scenario over and over again. A patient comes, you give them 100 or 200, they end up in the ICU, they do not want to be treated again. And also, because traditionally we let the white cell count drift without therapy, we started seeing patients with white cell counts of 100, 150, 200, 300. You cannot give a BTK inhibitor because they could go even worse. So as a group, we twisted the arms of Bill Weirda and Nitin Jain, and we developed a protocol where we give obinutuzumab for the high white cell counters, over 100,000. Obinutuzumab 50 with solumedrol 250 on day one, repeat 50 with 250 on day two, and then you do the 800 on day 3. Invariably, they tolerate it, the white cell count goes down, and then you can start the BTK inhibitor and venetoclax safely, and the venetoclax comes much earlier than after a month or two. So that's the protocol we're using now at MD Anderson, simply because we had case after case like this. And now the patients are coming with 200,000, 300,000. You cannot give a BTK inhibitor and think that it's going to be safe.
I would argue, actually, you can give a BTK inhibitor up to 100 or so. Certainly, 500, I probably wouldn't. But in all the trials that were done, people really don't develop leukostasis when given a BTK inhibitor with CLL. And actually, interestingly, we also don't do this that often, but If you give the BTK inhibitor before obinutuzumab, you actually really do reduce the risk of infusion reactions just because of the cytokine release.
All right, let's see what happened. As of 2025, the patient's disease is reasonably controlled on ongoing acalabrutinib therapy, but still desires a time-limited therapy. And Jen said we should try venetoclax. Oops.
So Jen, do
Oh,
you
it's
think
not there. And venetoclax was started about a week ago.
Yeah. So Jen, do you think she could have been cured if she would have gotten the right time-limited therapy from start?
I think it is unlikely, although I think she could have gotten a functional cure depending on her comorbidities and her life expectancy.
Yeah, I mean, to go Hagob's earlier point, I think, all of us could come up with regimens that we could give, about 10 or 15 different regimens that we could give for 20 years to keep this patient alive with sequential therapy over time. But I think our job as clinicians at academic centers is really to design the next generation of therapies that ultimately can help people like this to get time-limited therapy so that they don't have to get therapy to be cured of their disease. And I think that's our role.
I'm humble about the fact that we test those in a randomized trial.
All right, let's keep going. Do you guys have anybody's drinks empty yet? Please let me know. All right, so our next case, please show the slides. This is a CML case, so all the myeloid people are welcome to participate here. This is a 19-year-old who presented with massive splenomegaly. The history is a little bit sparse because she was out of the country at the time of presentation, but she was diagnosed with BCR-ABL positive chronic phase chronic myelogenous leukemia at the age of 19. Her initial therapy comprised of imatinib, and all I can say is that she did not achieve MMR. She was tolerating it, and the regimen was then switched to nilotinib, and still no MMR. And as of 2021, so that would be what, about 5 years into her journey? 4 years into her journey, she's on dasatinib, 50 milligrams BID, and as of October 22, no MMR achieved. You can see her quantitative BCR-ABL, no mutations were noted, and alternative TKIs were recommended, but no insurance coverage. So what should we be doing at this point?
So I have not a small number of patients like this. Obviously, the first order of business, especially with a young person, is to ensure compliance. Compliance is the most likely cause of failure of therapy. So despite what people tell you, they don't often take the drug. That's number one. Number two, when you don't comply with therapy, you set yourself up for clonal evolution. So number two, I would definitely check a secondary BCR-ABL mutation study. I mean, actually, the more they comply, the more likely they are to get a secondary mutation because they've got selection pressure. So, the question is whether this patient should go on, if they're really compliant and they have a secondary BCR-ABL mutation, most of which will respond to ponatinib or asciminib.
So no mutations as of October 22.
What's that?
No mutations were found.
No MMR achieved. Okay, well, no mutations.
And no mutations as well.
No mutations as well. That's not unusual because most people who are resistant to the TKIs. In this patient, I would probably, I don't know why they use dasatinib 50 BID. Usually the dose is 100 milligrams a day or 50 milligrams a day. But anyway, usually BID dosing is very hard for anybody, let alone a 19-year-old or she's now 22 or whatever. But yeah, so I would probably stick with dasatinib for a longer period of time. Now, I have patients who do not have MMRs, and they can be stable for quite a while. So I know we're supposed to get a MMR, which is less than 0.1%. But in this patient, I might go with dasatinib 100 milligrams BID and be damn sure she's getting worse and taking the drug before I switch, because she's down to only 2 other drugs, right? Bosutinib's not going to work, so that leaves asciminib, which may have a role here, and ponatinib, which may have a role here, and stem cell transplant, which we try to avoid at all costs in these patients. So I would probably not be so willing to switch. Keep her on dasatinib. If the BCR-ABL level goes up and she's really taking it and there's no mutations, I'd switch to ponatinib or possibly asciminib, which is supposed to work in this situation. In my own experience, it's not as potent as ponatinib, although the recent publication of first-line data suggests it is potent, at least in the short term, in terms of inducing a deep response. So I would go with 100 milligrams of dasatinib, not change yet.
But if you were to do ponatinib, will our age be a factor in your choice to say, hey, this patient is going to be on long-term therapy?
I don't start 19-year-olds on imatinib. I start them on a second-generation TKI.
No, I said ponatinib. Would you be concerned at giving a young patient like this ponatinib for a long period of time?
I'm not sure it's a long-term solution, but as people at MD Anderson have shown, you can, Dr. Cortez, formerly at MD Anderson, showed that you could start at a high dose, and then when they get into a good response, you can move to a lower dose. So if ponatinib was an option here, which there's no insurance coverage, that's a whole other issue, but ponatinib 45 milligrams for a month or two to get their PCR down, and then drop down to 30 or even 15 down the road. That was shown in the PACE trial by Cortez. Yeah, but for now, I would not switch off to dasatinib unless I saw that going up, even though she's not in a great response. I mean, this patient may end up in a stem cell transplant, which we rarely do anymore.
Can I?
Yes.
I need some clarification here. First of all, what happened to the spleen all this time?
The spleen got better, supposedly.
I'm sorry?
But this is all by history. Supposedly, the spleen was massively enlarged, and the time that she was being seen, the spleen was no longer enlarged.
So the spleen has responded?
Yes.
Okay. Now, the other question...
So she had a hematologic response, I think.
Yeah. What was the BCR-able transcript level when she was switched from one to the other to the other? So you just
No,
give us
that data is not available.
Huh?
That was outside of the country, so that data is not available.
So we don't know, so MMR was not achieved.
That's all that's known.
We don't know whether she has achieved cytogenesis.
No, nothing of that. None of that is available.
Okay.
So let me make a couple of comments. First, I agree with Dr. Stone. The most common cause of quote-unquote resistance is non-compliance, particularly in younger people. So I would ensure compliance. The second point is, if she was older, I wouldn't worry about a PCR of that level, because once you're under 1%, you could live your normal life. We have data also that shows now that it's not the 1%, it's the 10% level. So a partial cytogenetic response. It's the 10% level that really matters, and we're trying to negotiate with the ELN regarding this criteria. Now, she is young, so you want her to be in a complete molecular response. And there are 5 TKIs that you can use now. So you can either use ponatinib. I wouldn't do that. She's too young for that. But you could use only 15 milligrams a day. By the way, anytime you use a TKI in CML, I would advocate a baby aspirin daily. That reduces the incidence of thrombotic events. The second one would be asciminib, but asciminib is $300,000 a year. The 3 other options, which are $0 a year, are olverembatinib, TGRX 678, and TERN 701. If you get this patient on one of those 3 protocols, they will get the drug free for 5 years. So you might, if finances is an issue, you may want to try to get her into one of those 3rd-generation drug studies. So olverembatinib is like ponatinib, but much less toxic. And TGRX and TERN are STAMP inhibitors, like asciminib, and they are quite potent too. So these are options. By the way, I think we're underutilizing transplant. I don't think this patient, you should consider a transplant because the PCR is under 1%. But if she goes over 10% and you cannot do anything, transplant is still a highly curative, one-time option that we're underutilizing in patients who become resistant to a 2nd-generation TKI.
Did I once hear an erudite professor say that STI stood for stop transplant immediately?
That was me, and that was in the days when transplant was done upfront in every patient with CML when it was possible. When imatinib came about, I wanted to challenge the prevailing strategy. And I said, STI stands for stop transplant immediately, and I was booed. And I said that was the rumor. What I said was, select transplant intelligently. That was it.
So
All right.
I have a different take on this one,
Okay.
if I might say. This is a 19-year-old, and she presents, with a massive spleen, and then she shows you that she's not very responsive, even though she responded to multiple drugs. And this is a 19-year-old who's going to be whatever you put her on. There's new ones, whether it's overempatinib, shiminib, whatever it is. And who knows what could happen over years. So I don't know what we're waiting for here. So maybe we can get some drug, maybe we can get the BCR level a little lower, but she's going to be on it forever. And already she's telling you that she's got a biologically not very happy disease. I would probably transplant this patient. From the information you gave me, I would lean towards transplanting it rather than playing around with this and this and this, knowing that whatever it is, you end up, it's going to be for many, many years. And she's already told you that this is not a biologically malleable disease that she has. That would be my take. That's what I would
So Dr.
recommend.
Teferi is saying selective transplant immediately. But before we go, yes. Does AI have a tool yet for checking complaints?
But it doesn't matter. Listen, it really doesn't matter. If somebody is entrenched, they're not going to change their habit. So you might as well transplant them. Who cares about whether they're compliant or not? So I think that the treatment choice for non-compliance is transplant. You get it done. They're not going to get better by you educating them and just.
All right, February 25.
Do not
So she's
transplant
lost a follow-up.
unless she goes over 10% and you don't have other options. I have many, many patients who are older, 70, 80. They go at a level of 1 to 10%. I add decitabine, hydrea. They live their normal life. In chronic phase, not in...
But do you think, though, that maybe in a young patient, an important goal would be to try to get her to a point of not needing therapy, and it's important to get her into an MMR, molecular complete remission?
But if you
where
do the transplant now, the transplant mortality in 5-10 years is 20%. If you continue on a TKI and continue to suppress her, there's going to be several novel TKIs which are much safer and more effective. So I wouldn't do the transplant unless she exhibits true resistance. PCR over 10% and the bone marrow showing Philadelphia positive metaphases over 35%. So loss of a true partial cytogenetic.
I agree with Hagop on this one because also the fact is the patient's not a great transplant candidate. If she's lost a follow-up, imagine what's going to happen if she doesn't take her GVHD medicine. So I think we have a problem there too. So exhausting all non-transplant therapies for this particular patient might be a good idea, although I don't disagree with Ailu that she might come to it at some point. But I don't get that nervous about a PCR around 1% either, because I have lots of patients like that. The patient's PCR has been 20% for 10 years now. She's a special case because she doesn't do anything that she's told to do. But I think you have to meet the patient where they are. This one's a tough one for a variety of reasons.
So we agree to disagree.
All
We
right.
agree to disagree.
Well, not really. I just would wait until everything is.
This is our current status. So
This is an indictment of our country, unfortunately, as many things are these days. But yeah, I mean, I don't know if you think they're going to pay for a transplant. I don't know. Transplant's a lot less money than Semlex will be for the rest of her life, but it's still a lot of money.
Let me make a comment on the prices. I just got in touch with European colleagues, and we're publishing the price of TKIs in the United States and elsewhere. In the first debate I had with, it was at ASCO, I said that we pay in the United States twice as much the price of a drug compared to Europe. and the counter person said, oh, this is an exaggeration. We pay maybe 10 to 15% more. I'm looking at the prices now in the United States versus Germany, France, Italy, and Australia. And the asciminib, which is $300,000 in the United States, is available at $30,000 in many of the European countries. The same applies to dasatinib, ponatinib, nilotinib, and bosutinib. So it is truly an indictment of the for-profit system of healthcare in the United States that we should try to resolve at some point in time. Remember, 50% of the discoveries are made through the taxpayers' money, through NIH funding, and yet the Americans are penalized twice. They pay the taxes to make the discoveries, and then they have to pay much more for the drugs. Remember, it's not the insurers, because now they are paying 25% out of pocket. So the Joe Biden rule to cap the out-of-pocket to $2,500 applies only to Medicare. It doesn't apply to the self-insured or the self-pay. So really, it's a big problem still in the United States, and perhaps one solution is to be able to buy the drugs from elsewhere, because they are not only twice, they are sometimes 3 to 5 times higher in the United States than elsewhere.
Do you think the new administration will address that?
No, I think what Dr. Kalarajan is suggesting is that the pricing should be dosed.
By the way, dasatinib is now generic at about $3,000 to $5,000 outside the United States. Not in the United States. There are 2 generics in the United States, but because of the market forces, they are still at $150,000.
Because generic drugs, they give exclusivity to 2 companies after a drug goes generic.
No, they give exclusivity to one company. After 180 days, the second comes.
Right. So,
but I think there's some kind of
collusion?
I don't know what it is. But for imatinib, it took 15 generics, and even though they were coming out of the drug company at $5,000 on average, when they got to the patient, the average was $130,000 because of the group purchasing organizations and the pharmacy benefit managers. Until Cost Plus, the Mark Cuban came, and then the imatinib went to $500 a year. So hopefully, dasatinib will get into a company that sends it directly to the patient, and it will go under $5,000 too.
I just found out that Mark Cuban has not bought dasatinib yet, but hopefully he will.
He did buy it, but it's still very high.
Luke, come on.
Just a comment for this: the overratinib that it's available in Chicago.
Look, I don't think they can hear you. Too tall for the microphone.
We'll
pull the microphone a little bit. Yeah.
The investigational agent is available in Cleveland, Chicago, and we'll have it soon. So she could be seen at one of those places.
Okay. Cleveland, Chicago. She's lost her follow-up for 2 years. You think she will be traveling to Cleveland, Chicago, and where else did you say?
We'll have it. We have it.
Oh, okay. All right. So, our lymphoid friends haven't been involved in this conversation. We can't do that to them. So here is a 67-year-old man who presented with a 4 by 6 centimeter neck mass, which was noted about 4 weeks prior to their presentation to their physician. So the mass is not a temporary mass. Labs were normal, except for an LDH that was elevated at 350. Past medical history, hypertension, and the usual North American illnesses. A biopsy was done, and as you could see, it's a diffuse large B-cell lymphoma, likely germinal center type. PET scan is done, and it's a 4 by 3 centimeter right cervical lymph node. SUV is high, and additional adenopathy that was very small, that was not thought to be malignant, was noted. Otherwise, the main lesion is the right neck mass.
But he has additional adenopathy, both.
No, just some small shoddy adenopathy that didn't have significant SUV uptake.
But hypermetabolic.
Similar to all of similar SUV. I think they were, my recollection is that they were probably had an SUV of about 2 or something like that.
Okay, not bulky, but probably bigger than 1.5 centimeters, so enlarged, right?
Yeah.
Yeah. Yeah, so I mean, this is a fairly typical presentation of diffuse large B-cell lymphoma with the GCB subtype with an IPI score that would fall into the range of greater than 2, being older and having high LDH, I guess the PET scan doesn't describe whether or not he has bone marrow involvement or not on the PET scan. Was that
No, there was
described?
nothing in the bone or bone marrow.
Okay.
So are you suggesting a bone marrow biopsy or?
Not necessarily. I mean, I think on the PET scan that with PET scanning you can typically determine that at this point, and you can determine it to a degree that you don't really need to do it to make a treatment decision at this point.
Would you try to biopsy any of those small lymph nodes?
Any of those small lymph nodes? Not necessarily. I mean, I think you've got enough to confirm a diagnosis of diffuse large B-cell lymphoma. You know, typically at our center we would have the pathology reviewed just to confirm that, but those include all the typical characteristics that would
So what should we do next?
be aligned.
Give Viper?
What's that? Viper? No, I mean, I think this is a person I do worry a little bit about his hypertension and dyslipidemia, and would want to know to make sure that he had an adequate echocardiogram and was, you know, fit for standard chemotherapy. Yep. Yeah, so that I think that all goes along with everything that I said.
6 cycles of R-CHOP, end of therapy, PET, CR.
Yeah, so it depends on the year in which he was treated. You know, the Polarix data were published at the tail end of 2022 and approved by the FDA. This would be a candidate for Polar-CHP as a standard regimen in the current state, having an IPI score greater than 2. I think one of the things that would raise some concerns for some people about that, as you heard in Sony's talk, was the fact this is a GCB DLBCL. The challenge there is this is germinal center by immunohistochemistry, where we know with immunohistochemistry there's about 20% misclassification. And if you were to treat based on that IHC characteristic to choose R-CHOP or Polar-CHP, you would treat about 20% of the people the wrong way each time. And so I don't use that. I use just IPI score to make the decision about treatment. And so this is a patient that we would typically have either put on a clinical trial or treated with Polar-CHP in that setting. But I think R-CHOP is also a standard of care and potentially a reasonable regimen. But at the end of treatment, having an end of treatment PET scan negative is as good as things can get.
6 months?
But doesn't always work out. And I assume that was the case, because otherwise it wouldn't have gotten presented as a standard R-CHOP cure. Yeah, so this is somebody with an early relapse of diffuse large B-cell lymphoma. I think the recurrence of a mass does make you concerned anytime you see a recurrence, so you want to biopsy it to confirm the evidence of relapse.
So biopsy is done and it confirms it. What would you do next?
Yeah, so with early relapse disease, so this is a patient that fell into the categories that you heard about earlier from Matt, that would be a candidate on the ZUMA-7 trial for the use of CAR T cells as an early relapse patient.
What will be your CAR T of choice?
Yeah, so I would give Axicell. Axicell is the only one that has a proven overall survival advantage. Given that this patient appears to be reasonably young and healthy, that would be the standard of care, at least at our institution. Lysocell would be another option, but Axicell would be our preferred choice.
All right, you know, Aiello has been very quiet.
Yeah, aspirin.
All right, so this is a 78-year-old female who was diagnosed with primary myelofibrosis based on previous workup, JAK and CAR negative, MPL positive, AXL negative, and SSRF2 positive. And this was diagnosed in 2016. I'm not sure what the initial prognostic index was, but let's just say it was low risk. That's how it was called, and the patient was on surveillance until they developed progressive anemia. So the patient sees you, Dr. Teferi. At this point, what would you do? Should I start ruxolitinib? I should have started it the year before, or what's wrong with me?
So she has a high-risk mutation, which is SRSF2. I don't know what the cytogenetics are. Do you, by any chance?
I believe it was normal, but
Okay.
I might be making it up.
So she has an SRSF2 high-risk mutation, and she's got progressive anemia. Phenotypically also, she's progressive.
No, so this is before. So she was diagnosed, initially diagnosed in 16, and this is about a couple of years later.
Yes.
So what I'm saying is that on the basis of the initial presentation of that mutation, should she have been treated immediately, or should we have monitored her until she had progressive anemia? Because at that point, the patient had no significant anemia.
So these are very tricky situations. I don't think we can decide on one static time. So if a patient is perfectly fine, they just have one bad mutation, doesn't mean that they go to see the transplanter right away. Even though at age 78 now, some people are considering transplant. So in the beginning, if that was the only mutation she has, I usually like to look at the VAF also, the variant allele frequency, whether it's a small clone, what have you. But let's say that it was a decently high clone. I would say, okay, that's the only problem you have. I'm not going to jump up and down, but I'm going to keep an eye on you. So I will just probably monitor and recheck the SRS, the NGS, maybe every 3 months, because it is a high-risk mutation. And so that's what I would do. So the initial monitoring, I think, is appropriate, taking the age into consideration. If it was a younger patient, I will have them also consult, not necessarily get the transplant, but at least consult with the transplanter to get the info. Now, then she progressed with anemia. So now she's at a position where if she was young, she would definitely need to get transplanted. Now, here is the question, is the age. And that's really depends on the shop. Like I have colleagues who would consider 78 young enough to pursue transplant.
Dr. Kalaraja said we all be 75 in 5 years. So really, you're talking of all of us, that's 3 years younger.
Yeah, no,
so that's not that old.
I have patients this age that were transplanted and did well. I have patients much younger and did very bad. So it actually depends on the biological age more than the chronological age. But regardless, I think to discuss about it, it's not going to harm anything. Just because she's 78, you don't necessarily deprive her of that hope, that possibility. So I think having it talk to the transplanter provides that comfort that you have addressed all angles, and the patient feels good about it, and then they will decide. They will listen to what it is all about from the transplanter and all the inconvenience, the mortality and the morbidity and what have you. So at that point, let's say that this patient desires is a go-getter.
Welcome to the land of us.
I will finish next year. Then,
okay,
right?
we're going to finish the case. All right, so the patient is treated with dabapuertin and for the anemia. Is that reasonable?
What was their EPO level?
I think the hemoglobin was around 8.
No, the erythropoietin level.
Let's say it was 400. No, let's say 300.
So I think what you are giving us is that this patient, everything was all allowed.
Okay, 2, please. 2.
So I think what you're saying here is that the patient has decided not to go with transplant,
Yes.
and you are going to treat her to make her quality of life good, because no matter what kind of treatment you give her, you're not going to prolong her life. So there, anything goes. Whether you want to start danazol, you want to start darbepoetin, whether you start thalidomide with prednisone in order to improve the anemia, anything goes. I don't think anyone can say, this is the first one you should try, this is the second one you should try. There is no such thing. I usually look at the erythropoietin level. If it is below 100, that's reasonable to do.
Okay, so erythropoietin started with, Sumit, I'm going to get you on, don't worry.
Is the spleen big or not big?
But then the patient doesn't respond, so momelotinib is instituted, but then discontinued because of renal dysfunction. And pacritinib was then instituted, but discontinued because the patient is not responding.
Why were you using those things when she had anemia? I mean, that's, what was the reason for? Because
no, they started with momelotinib when she was anemic.
But
so
why? The indications for those drugs are either bothersome splenomegaly or symptoms. Did she have either of those things?
She did have a massive spleen and had constitutional symptoms.
Okay.
So when she was being treated, after the momelotinib was started because of symptomatic anemia and constitutional.
That makes sense.
we got a reprieve of 2 minutes.
So let me so I agree 100%. Yeah. So let me.
Please. No, please.
So I agree with Rich that if the problem is anemia, use an anemia drug. There's no reason to use other drugs. I mean, there are so many alternatives before we go to the big guns. However, I want to make a couple of points. Momelotinib does cause renal dysfunction. So if you have patients on momelotinib and their creatinine is going up, you can attribute it to the drug. That's number one. So that was appropriate to discontinue it. Number two, pacritinib, lack of response. That is true. It doesn't work. We have only 1 of 47 patients in real-life study that responded with anemia. 1 of 47.
So, luspatercept and danazol was started, but the danazol was discontinued after 2 cycles because of profound fatigue.
Fatigue. It's notorious for doing that.
Did you give, so now it looks like you are exhausting the available drugs for anemia and she's still not responding.
Yes.
So, one of 2 options. One, just give her blood transfusions, and that's it, number 1. That's one option. Make her feel better. Second option is clinical trial. For example, we have the DISC 0974 where we use hepcidin suppressor to improve anemia, and there are other clinical trials.
But what would you do for the splenomegaly what would happen to the splenomegaly?
I'm sorry?
What would you do for the splenomegaly? Or is the fact that she's responded, would that be a reason not to worry about the splenomegaly, or will this be one of the ones you take to a splenectomy? Because remember, she has splenomegaly initially. That's what Sumit just said.
No, she has now splenomegaly?
No, but she did before.
Yeah, she did before.
Yes.
That's fine.
When you stop the JAK inhibitor, don't you expect some kind of rebound splenomegaly?
Not necessarily. It depends. It depends on how big it was before you started. It usually depends. If it is just not a big spleen, well, maybe it goes back to that mild splenomegaly. A lot of people live with mild splenomegaly. That's not an indication to intervene necessarily.
Single agent danazol on the basis of this was caused by luspatercept.
Well, first of all, danazol is not going to work in 3 weeks. Okay? So,
But this is a tolerance issue. She's feeling worse.
No, I understand. But danazol is not going to work for 3 weeks. But if she's not tolerating it, she's not tolerating it. Why don't you just give her thalidomide and prednisone?
Thalidomide?
And prednisone.
All right, so the spleen is not changed. Now the patient develops proteinuria and trigeminal neuralgia, still feeling poorly. Hemoglobin is 9.2 with transfusions weekly. Anything else? Rami, you're so quiet. You got to say something on this case.
Yeah, I think the only thing that was not tried, you can try thalidomide for the anemia, thalidomide prednisone. It doesn't, like, probably the responses are in the range of 20-25%, but when we see responses, they are durable. I agree with the comments that if patients did not have spleen or symptoms, like this is still always in the community that, you know, the first reflex is to use ruxolitinib. Ruxolitinib causes anemia, does not improve anemia. So unless the patient have symptoms like spleen, we should not choose JAK2 inhibitors. So in this case, I would have gone to like the danazole or the thalidomide. I think the only thing that the patient didn't try yet here is thalidomide. So I'll do thalidomide prednisone, sometimes steroids alone. That's the only thing I can think of if patient cannot go on a trial.
So
All right,
let me.
Sumit, now you can finish up.
I think this is what it's coming to because she was actually offered the clinical trial at Mayo, but she did not agree to the hepcidin trial somewhere along the way. I don't know where that was. But in the interim, right now, she's tolerating danazole really poorly, so we are down to thalidomide. And I actually did offer her the ability to talk about a transplant. And Dr. Teferi, if I'm not wrong, she's going to have a video visit with you again about it.
Yeah, well, absolutely, absolutely. Now, let me just say, because this is important. So let's assume that you tried everything, and she's still requiring transfusions. And people forget that splenectomy provides 50% response rate. And now they can do laparoscopically. And 78, this is not transplant. She can tolerate that. So if she's not responding to anything, I think it's very reasonable to do splenectomy and expect a 50% response.
Would you do it before thalidomide or after?
You can try thalidomide, but I'm assuming that you have exhausted everything under the sun. You can try thalidomide and lenalidomide. They're not going to work. Even if they're going to work, it's just going to
What dose of thalidomide would you do?
I'll just take the spleen out because this is requiring transfusions every week. This is not normal.
Yeah, her white count's now up to 50,000, and honestly, her performance, she's a young 78. She's a pretty good 78, and so the question actually I think she's going to ask you next week is, should she go for transplant?
Does she have any blood differential?
So
she could be transforming.
I will tell you what she needs to do, then she doesn't have to come and see me.
And with that, I'd like to thank all of you warriors that stayed for our 22nd Indy Hematology Review. We'll see you here on March 7th of 2023. We should give a hand of applause to, 2026. Thank you, guys.